Hello everyone and welcome to another endoscopic case presentation. This case highlights a very serious and unusual cause of an upper GI bleed. The patient is a 64-year-old man who 8 years ago had an out-of-hospital cardiac arrest. He had a stent inserted into his right coronary artery and an ICD device was installed because of ventricular arrhythmia. He also had a history of COPD, sleep apnea, mild LV impairment and depression. His usual medications were aspirin, omeprazole, bisoprolol and a number of other tablets as listed here. He was an ex-smoker and had been drinking heavily for about 3 months prior to admission. He was brought into hospital by ambulance with several episodes of rectal bleeding. He was passing altered blood and possibly melaena as well. He had been drinking half a bottle of rum per night for the previous 3 months. On examination, he looked unwell. The heart rate was 81 beats per minute, but he was on a beta blocker, and the blood pressure was 52/46 millimeters of mercury. The abdomen was soft and non-tender, and a digital rectal examination showed fresh blood mixed in with black stools. The initial hemoglobin was 123 grams per liter, and the urea was raised at 8.4 with a baseline of 3.6. The INR was normal at 1.0. Clearly he was in shock. The major hemorrhage protocol was activated. He received 1 unit of blood, 2 liters of Hartmann's solution, and was commenced on a metaraminol infusion. The blood pressure improved. He was seen by the surgeons and a CT scan with contrast was performed. This did not show a source of bleeding. The blood pressure stabilized and the metaraminol was discontinued on day 2. An upper GI endoscopy showed no blood in the upper GI tract and was reported as being normal to the second part of the duodenum. An inpatient colonoscopy and CT angiography were recommended. The hemoglobin came down to 109 despite the blood transfusion, and the urea went up further. However, the patient was hemodynamically stable. On day 3, the hemoglobin drifted down further to 90 and a CT angiogram was requested. On day 4, the hemoglobin fell further to 68 and 2 more units of blood were transfused. A second endoscopy was performed and showed fresh blood in the second part of the duodenum, but the source of the bleeding was not identified. The possibility of a duodenal Dieulafoy lesion was postulated by the endoscopist. A subsequent CT angiogram did not show a source of bleeding, but there was slight hypodense contrast in the transverse and descending colon of uncertain significance. On day 5, the hemoglobin was 62 despite the 2 units given the previous day, and a further unit of blood was transfused. A third endoscopy was performed using both a forward-viewing endoscope with distal attachment and a side-viewing endoscope. No blood was seen and no source of bleeding was identified. There was a red spot in the duodenal bulb of uncertain significance, but a clip was applied to it anyway. By day 6, the patient had received a total of 4 units of blood, but still looked pale and was tachycardic. He had fresh melaena and the hemoglobin was 60. Hence, 2 more units of blood were transfused. He went to the endoscopy unit for a scheduled colonoscopy, but in view of the fresh melaena, it was decided to repeat his upper GI endoscopy. We will now see the video of this endoscopy, which is his 4th one. We join the endoscopy in the second part of the duodenum. There is fresh blood visible. As we go further in, there is more fresh blood and fresh clots in the third part of the duodenum. There appears to be a diverticulum in the third part of the duodenum, seen in the upper left of the image. Fresh blood is pooling in this area, and there is a clot near the diverticulum. The scope is in almost to the hilt, and it is difficult to manipulate the tip. With some difficulty, we are able to insert the tip of the scope into the diverticulum, where we see a spurting blood vessel on the wall of the diverticulum. Finally, we have identified the source of the bleeding. It is an actively bleeding Dieulafoy lesion in the wall of a diverticulum in the third part of the duodenum. My first thought at this point is to put a clip on the vessel. I pass a Boston Resolution 360 clip down the channel of the scope, but because of the sharp angulation of the tip of the scope, the clip gets stuck and refuses to come out of the scope. Therefore, I pull the scope out of the diverticulum, straighten the tip, push the clip in until it is just out of the scope, and then try to get back into the diverticulum. The views look slightly different now. A spurter is no longer visible, and there is pooling of blood in the lower part of the diverticulum. There appears to be a pulsation coming from the pool of blood. At this point, I decide to remove the gastroscope and try with a longer pediatric colonoscope instead. On reintubation with the colonoscope, we find more fresh blood in the duodenum, with a large clot in the third part of the duodenum. After washing with water and suction, the views are improved, and I eventually re-enter the diverticulum. There is blood in the lower portion of the diverticulum. I instill 6 mils of Purostat into the diverticulum in the hope that this will buy me some time. The advantage of Purostat is that it is transparent and allows you to continue with other types of endotherapy, something that you cannot do with hemostatic powder sprays. After instilling the Purostat, I have another try at clipping, this time using a Locado 16mm clip. The vessel has stopped bleeding, but it is not clear where the vessel is. I place the first clip near a dark spot on the wall of the diverticulum, which I mistakenly take to be the vessel. I aim to place the second Locardo clip to the left of the first one, closer to the dark spot. As I deploy the second clip, I notice a pale raised area at 7 o'clock. This is almost certainly the vessel that we have been searching for. It is important that the next clip targets this vessel. However, the angle is difficult and views are not optimum. Initially, the clip slides off, but with a little manipulation and torquing, we're able to place the third clip on the vessel. After this, a fourth clip is placed adjacent to the third clip. The purpose of the extra clip is to cut off the blood supply to the feeding vessels which may be running in the folds of the diverticulum. We now switch to a duodenoscope, which is a side viewing instrument. The diverticulum is located in D3 and we can see the 4 deployed clips. There is no bleeding now. A fifth clip is deployed via the duodenoscope. This is probably unnecessary, but I do it anyway. After the endoscopy, we decided not to do the colonoscopy in view of the findings. The patient remained hemodynamically stable overnight and the hemoglobin on day 7 was 68. Hence a further unit of blood was transfused. We performed a further endoscopy, this is the 5th one, on day 7 using a pediatric colonoscope. There is no blood in the duodenum and we can see the 5 diploid clips still attached in the diverticulum in the third part of the duodenum. One of the clip appears to be pulsatile, and I decide to place a further clip adjacent to the pulsating clip. Again, this is probably not necessary, but the mortality from an inadequately treated Dieulafoy lesion is so high that I did not want to take any chances. The patient remained well after this endoscopy. His hemoglobin remained stable at 70 grams per liter, and he was given a pharyngect infusion on day 8. Also, he had an IV omeprazole infusion for 72 hours after the diagnosis of Dieulafoy lesion was made. This chart summarizes his first 10 days in hospital, and you can pause the video to examine it. Finally, let us take a look at the CT angiogram, which reported no source of bleeding. We can see in this coronal section a large diverticulum on the superior aspects of the third part of the duodenum. Blood vessels can be seen supplying the wall of the diverticulum. These vessels are likely to be branches of the inferior pancreatico-duodenal artery, which gives off an anterior and posterior branch. The inferior pancreatico-duodenal artery originates from the superior mesenteric artery. It is likely that the Dieulafoy lesion that we saw in the diverticulum is a branch of either the anterior or posterior branch of the inferior pancreatico-duodenal artery. I hope you enjoyed this rare endoscopic case. See you in the next one. Bye for now.